All right, welcome to this explainer. Today, we are completely ditching the textbook and jumping straight into the practical, nitty-gritty treatments for bladder dysfunction. From neurogenic overactivity all the way to acute retention, we're going to break down the exact receptor mechanisms, those really crucial clinical nuances, and the precise drug dosages, point by point. Let's get started.
Here is our roadmap for today. We'll start with anticholinergic mechanisms and specific drug profiles, then move on to alpha blockers. After that, we'll look at botulinum toxin, explore implantable neuromodulation, and finally wrap up with managing acute retention.
Section 1. Anticholinergic mechanisms and broad effects. Let's look at how these foundational agents actually work.
So bladder contraction is normally driven by acetylcholine, right? By blocking the M2 and M3 receptors, these drugs step in and prevent that parasympathetic stimulation. Clinically, what does that actually mean? Well, it physically stretches the bladder capacity by an average of 50 milliliters, and this is the big one. It drops storage pressure by 15 centimeters of water. That pressure drop is absolutely vital for protecting the kidneys.
But if you push the dose too high, you're going to see some dangerous systemic side effects. You probably know the classic medical mnemonic: red as a beet, hot as a stove, dry as a rock, mad as a hatter. It's a vivid way to lock into your memory the flushing, the fever, the decreased sweating, and the delirium that can literally take over during an overdose.
Because these agents act systemically, their everyday use is often pretty limited. Patients frequently complain of dry mouth, constipation, blurry vision, and, ironically, urinary retention. And here's an absolute must-know. These drugs are strictly contraindicated in patients with glaucoma because they induce pupil dilation. We also have to be highly vigilant about their negative impact on cognition and memory, especially when we're dealing with older patients.
Section 2. Specific anticholinergic medication profiles. Now, let's break down how these distinct medications stack up against each other.
Comparing our first two heavy hitters, oxybutynin is widely prescribed, and it's actually unique because it has independent muscle relaxant and local anesthetic effects. The catch? It produces the highest rate of side effects, especially if you're using the immediate release version dosed up to 3 times a day. You can usually manage this a bit better with the extended release or the 3-day patch. Then you have tolterodine, which offers a much milder side effect profile though. Trade-off time, it might be slightly less effective overall.
Moving to our next pair, sulfaphenacin and daraphenacin. Both are typically dosed between 5 and 10 milligrams daily. But here's the thing you really need to remember. Sulfaphenacin stands out specifically because it causes the most constipation within this entire drug class. So, if your patient already struggles with complex bowel regimens, that is a massive red flag.
Finally, for this group, we have physotyrrhodine and trospium. Trospium has an absolutely unique chemical structure. Unlike the others, it's a quaternary amine. Why does that matter? Well, quaternary amines cross the blood-brain barrier much less readily. This effectively shields the central nervous system, which means far less negative impact on cognition and memory. Honestly, it's a total lifesaver for our neurologically vulnerable patients.
Section 3. Alpha blockers. Let's talk about opening the exit doors. So unlike anticholinergics that target the main detrusor muscle, alpha-adrenal receptor antagonists target the alpha-1 receptors that are located primarily right on the bladder neck. By blocking these receptors, you relax the smooth muscle at the exit. This directly decreases outlet resistance and indirectly lowers those overall storage pressures. They are phenomenal for treating voiding difficulties caused by benign prostatic hypertrophy.
Of course, you've got to watch out for side effects across this class, things like postural hypotension, rhinitis, and retrograde ejaculation. But there is a really fascinating secondary benefit here. Agents like terazosin can actually decrease the frequency and severity of autonomic dysreflexia symptoms. Now, because dangerous hypotension is super common in non-selective drugs like terazosin and doxazosin, you absolutely must ramp up their doses gradually over time.
Now, tamsulosin is a star player for acute relief, but it requires a very specific dosing protocol. Because it's a highly specific prostate alpha-1A antagonist, you don't need a ramp-up period at all. You can start right at the therapeutic dose of 0.4 milligrams orally, once a day, usually 30 minutes after the same meal. Just keep in mind, while you get to skip the ramp-up, it is still going to take about 5 to 7 days to fully kick in.
Section 4. Botulinum toxin. Moving on to some direct muscular interventions.
We just talked about anticholinergics blocking receptors, while botulinum toxin A stops the neurotransmitter from even showing up to the party. By inhibiting the actual exocytosis or release of acetylcholine, Botox chemically paralyzes that overactive detrusor muscle. Procedurally, we inject between 100 and 200 units directly into the muscle during a cystoscopy. And the result? Brilliant relief from urgency and pressure that lasts anywhere from 3 to 12 months.
360. That is the magic number. Or rather, it's an absolute hard limit. You cannot exceed 360 units of Botox in a 90-day window across all sources. No exceptions.
And we must always warn patients about this specific risk. There is a 2 to 20% risk that the Botox actually relaxes the bladder a little too much, throwing the patient into acute urinary retention. If that happens, they're going to require temporary catheterization for weeks or maybe even months as the toxin gradually wears off.
Section 5. Implantable neuromodulation. Let's look at some really advanced therapy.
Permanent implantable neuromodulation is strictly reserved for truly refractory cases. How it works is you first place a temporary trial lead adjacent to the sacral nerve via the S3 foramen. To actually qualify for the permanent implant, the patient must experience greater than a 50% reduction in their symptoms. Oh, and a crucial safety note, the permanent device is MRI conditional for the head only, at 1.5 Tesla or less.
But man, this is an incredibly effective intervention. When patients are properly selected, up to 70% see a marked improvement in their symptoms, and nearly 39% find complete total resolution of their incontinence. For a patient who hasn't responded to anything else, that is absolutely life-changing.
Section 6. Managing acute urinary retention. How to handle a crisis.
If a patient hits a crisis like acute retention, you need to follow this strict 4-step pathway. Step 1. Intervene early. You have to avoid over-distending and permanently injuring that detrusor muscle. Step 2. Initiate catheterization, strictly keeping drained volumes under 400 milliliters per pass. Step 3. Start alpha blockers like tamsulosin right away to lower the outlet resistance. And step 4. Always loop in urology for long-term management.
We've covered an immense amount of ground today. As we wrap up this explainer, I want you to consider this. As we get better at pinpointing the exact neurourologic deficits in individual patients, how might these diverse mechanisms be combined in the future to completely eradicate treatment-resistant bladder dysfunction? Thanks for joining me on this deep dive, and keep asking the big questions.